thankful that our delegates have joined our meeting and our chairperson, our panelists have accepted our invitation and joined here at this time. Uh, I will just introduce Dr. Professor Dr. S.K. Singh, and then he will take over the webinar. Professor S.K. Singh has an illustrious career and is a renowned, distinguished, and a prominent figure in the field of endocrinology. He is a professor in Department of Endocrinology and Metabolism at Banaras Hindu University at Varanasi. His area of practice revolves around endocrine disorders and hormone problems. Sir has given very short CV. So, with this, I will hand over to Professor S.K. Singh. Thank you so much.
Thank you, Dr. Gurunath, for your kind words, and thanks to Samarth Pharmaceutical for giving this opportunity to have this webinar on adrenal medicine, adrenal insufficiency in children, and hypopituitarism. First of all, I thank all the chairpersons, Dr. Nilanjan Sen Gupta and Dr. P.K. Jabbar, who will co-chairing this session, and Dr. Boro would be presenting the case and will be involved in discussion. Dr. Rasa from Egypt is our international expert, and I'm sure we'll be benefited by her experience of managing adrenal insufficiency. So I request Dr. Nilanjan Sen, who is known to almost every audience in endocrinology, who is right now working in NRS Medical College, Kolkata, is heading the department, and Dr. P.K. Jabbar, who is from Thiruvananthapuram, is also heading Department of Endocrinology. So I'm very fortunate to co-chair this session with these two great, very dynamic academic endocrinologists of our country. And I'm sure you will be benefited by this case presentation and following discussion. Over to Dr. Nilanjan and Dr. P.K. Jabbar for brief introduction of the subject.
Well, good evening, everybody. I think I thank Endocrine Society and Dr. S.K. Singh for formulating these sort of very interesting, interactive sessions on endocrinology. And this evening, we have an interesting adrenal case by Dr. Boro, Dr. Hia Boro, who is from Hisar, is a consultant endocrinologist out there. I don't want to stand between the case presentation because we will be having a detailed discussion after she presents. So may I request Dr. Hia to present the case? Maybe Dr. Jabbar can add one or two sentences prior to Dr. Hia taking over. Dr. Jabbar, please.
I'm very happy that I'm chairing with two stalwarts, probably senior most endocrinologists in our country. I don't want to make any comments now. Over to speaker. After that, we'll have a discussion. That time I'll make my own comments. I think over to Dr. Hia.
Thank you, sir. Really fortunate to be amongst the stalwarts of endocrinology in India. Instead of wasting time, I'll straightly go to the case. So this case is about adrenal insufficiency in children. This was a case which I saw in my DM tenure in All India Institute of Medical Sciences, New Delhi. So let's begin the case. Anubhav, can you move my slide?
Anubhav, do enable editing and then go for slideshow, complete slideshow.
Anubhav? Yes. Our patient is a 16-year-old female. Sorry. Our patient is a 16-year-old female. Our patient is a 16-year-old female. She is first in birth order. She is born out of non-consanguineous marriage, and she has had normal vaginal delivery, and she had uneventful antenatal and intranatal histories. And immediately after birth, her parents noticed that the child did not produce tears while she cried. And one more important thing is that the parents also noticed that she did not produce saliva. And this patient, she was exclusively breastfed for the first year of her life, and after which subsequently complementary feeds were introduced. One interesting thing that was noted by the parents was that whenever she was given breast milk, she used to regurgitate the feeds. And parents also noticed that whenever complementary feed, including liquid diets, were introduced, she had gagging, and she used to regurgitate both solid and liquid food whenever it was fed to her. Anubhav, next slide. Next, next slide, please, Anubhav. Patient used to eat, sorry, patient used to eat very small amounts of food, and she also complained of frequent episodes of retrosternal pain, and this was usually aggravated by intake of meals. And because this patient ate very less, she failed to gain adequate weight, and however, her height was comparable with that of her peers. And gradually, her symptom of dysphagia worsened. Then, at around 7 years of age, the parents took her to a pediatrician, and this pediatrician referred her to a gastroenterologist. She was then advised endoscopic intervention for dysphagia. However, the patient's family did not comply with the advice. Next slide, please. At around 7 to 8 years of age, there was insidious onset, gradually progressive darkening of her skin. This initially started at the extremities, and later on, gradually it involved other parts of the body. And within 1 year, there was darkening of her face, lips, oral mucosa, tongue, and knuckles. Patient also had history of generalized weakness and easy fatigability, and she remained the thinnest of all her siblings and peers. And in the assembly line, which was arranged according to the height, she used to stand in the third and fourth position. Next slide, please. Patient also gave history of dizziness on and off that worsened on standing. She also gave history of frequent episodes of salt craving. And on many occasions, when the patient was taken to a pediatrician, the blood pressure records that were maintained, this showed a value of around 70 to 40 millimeter mercury. That was on the lower side. And patient also had history of recurrent abdominal pain. However, there was no history of recurrent vomiting. There was also no history of diarrhea or constipation. Next slide, please. There was no history of evening rise of temperature or cough or hemoptysis. There was no history of vitiligo. There was no history of generalized swelling of the body, weight gain, or any neck swelling or constipation. There was also no history of pedal spasm, recurrent facial grimacing, numbness of the extremities, or any history suggestive of tetany. There was also no history of any fungal infection of the nails, skin, or oral mucosa. There was also no history suggestive of premature adrenarche, that is, premature appearance of pubic or axillary hair. There was also no history suggestive of precocious puberty, like precocious breast enlargement or accelerated height spurt. There was also no history of contact with any patient diagnosed with tuberculosis. Next slide, please. Then all the symptoms continued. Then around 9 years of age, a patient was taken to a pediatrician, and that pediatrician diagnosed her as a case of primary adrenal insufficiency. Now, this patient presented to us at 16 years of age, and when she presented to us, her initial cortisol and ACTH reports were not available. Then, when we searched her records, we found that she had taken tablet dexamethasone, that is tablet Dexona, in variable doses during the initial years of her diagnosis. And after taking Dexona, the mother remembers very clearly that the patient had developed weight gain and mild roundening of her face. There was, however, no other obvious features of Cushing's like stria, ecchymosis, bruising, or proximal myopathy. She was also taking tablet fludrocortisone. The dose was around 50 microgram once daily for the initial few months after diagnosis. And then because the patient left her medicines on her own without consulting any doctor. Next slide, please. Next. Next slide, Anubhav, please. Slide number 9. This is her family history. This family history showed that this patient was a product of non-consanguineous marriage, and she had a younger sister and a younger brother. Now, this was our patient. She had a younger sister who was around 12 years of age. This younger sister was, however, not evaluated, but she also gave complaints like erythemia, diffuse hyperpigmentation, and this pigmentation involved the tongue, the oral mucosa, palms, and knuckles. And this patient had not undergone evaluation. Now, our patient had attained spontaneous breast development at around 10 to 11 years of age. She had also attained menarche at 13 years of age. And initially, her cycles were oligomenoric, but for the past year, she is having regular menses. Now, the patient was continuing like this. Then, before presenting to us, that is 6 months prior to the current presentation, patient developed osmotic symptoms in the form of polyuria, polydipsia, and weight loss. And she also had vulval itching, and she then went to a physician, and that physician checked her random blood glucose, and that random blood glucose was recorded to be high. That was around 245 milligram per dl, and however urine for ketones was negative. There was no history suggestive of diabetic ketoacidosis like shortness of breath or any other symptoms suggestive of diabetic ketoacidosis. Then that physician started her on human insulin mixture 30 by 70, 8 units subcutaneous before breakfast and 4 units subcutaneous before dinner. Patient did not receive any formal counseling on diabetic diet. Her insulin technique was also not appropriate. She used to inject the insulin on her arms, and because she came from a poor financial background, they did not have refrigerator at her house, and so she used to store her insulin on the ardent pots, and then she used the same needle for around 4 to 5 injections. And she also never did any SMBG, nor did she follow up with any doctor for diabetes. Then after 2 months of insulin, patient again stopped it herself without consulting anyone. Then, while she was off insulin, she never developed any history suggestive of diabetic ketoacidosis. Then, after consulting a local, maybe a chemist or a doctor, the family started her on tablet metformin 500 milligram once daily. And when she presented to us, she was on tablet metformin 500 milligram once daily. And this was her current presentation at 16 years of age when she presented to All India Institute. And she presented to us, before she presented to us, she was having episodes of fever for the past 3 to 4 days, which was associated with chills. And this fever was accompanied by burning micturition. She presented to emergency with multiple episodes of vomiting. She also had moderate to severe intensity pain abdomen. And she also gives history that she had missed the dose of hydrocortisone for 2 days prior to coming to the emergency. Then at the emergency room, the patient was examined by the emergency resident physician. She appeared to be lethargic. She was dehydrated. She was drowsy. However, she was responding to the verbal commands. And the vitals recorded in the emergency were the pulse rate was high. It was 120 per minute. It was regular and feeble. The blood pressure was on the lower side. It was 70 by 30 millimeter mercury in the right arm supine position. The respiratory rate was also high. That was around 28 per minute. And she was also having fever. Temperature was around 102 degree Fahrenheit. And she was, however, maintaining saturation at room air. It was around 96% in room air. Then the emergency resident physician, because she had a background history of darkening of skin, and all these symptoms actually coincided with acute adrenal crisis. So the emergency resident physician, she suspected acute adrenal crisis. Then samples were collected for electrolytes, complete blood count, serum cortisol, and plasma ACTH. And after that, after collecting the sample, two large IV cannulas were put, and normal saline was initiated. That is 0.9% isotonic saline was initiated at the rate of around 150 ml per hour. She was also administered injection hydrocortisone 100 milligram IV stat, and this was followed by 100 milligram IV TDS, that is twice daily. And random blood glucose was also checked, which was around 145 milligram per deciliter. and blood glucose and vitals monitoring were advised 2 hourly. And in view of fever, IV antibiotics were also administered. Next slide, please. After measures after initial stabilization, in emergency, the patient was shifted to the endocrine ward, and IV fluids are continued at a lower rate of 100 ml per hour. Then injection hydrocortisone was also continued, and then the doses were tapered off, and IV antibiotics were continued for 5 days, after which the fever resolved. And within around 12 hours, the patient became stable. The vitals were also stable. Blood pressure rose to around 100 by 60 millimeter mercury. The pulse rate normalized, became around 80 per minute with regular and normovolumic pulse. The respiratory rate also calmed down, and rest of the general and systemic examinations were within normal limits. And when she was stable, we also did a neurological examination, and we found that the neurological examination of the patient was normal, including examination of the cranial nerves, sensory and motor examination. Next. Now, these are the clinical pictures of the patient. This was our patient, who is a 16-year-old female, and she has having this history since birth. She was whatever food is given to her. She is the thinnest among all her peers. And then she was diagnosed as a case of adrenal insufficiency at around 7 to 8 years of age. And she presented to us at 16 years of age with history suggestive of acute adrenal crisis. Now, this clinical picture shows diffuse hyperpigmentation of the skin. And this figure shows hyperpigmentation of the lips. The lips are totally pigmented, and there is also pigmentation over the dorsum of the tongue. And in this picture, we are seeing classical knuckle hyperpigmentation that is seen in primary adrenal insufficiency with background darkening of the skin. Next.
I think, Dr. Barrow, can we just go back, because the history had been quite long.
Next slide, please.
So, Dr. Barrow, am I audible? Hello, Dr. Barrow? Dr. Hia? I think we lost contact.
So she has some connectivity problem, I think.
Okay. Dr. Nilanjan, are you?
Yeah.
Dr. Nilanjan? Yeah.
Yeah.
Should we ask her to just summarize the history before going into the investigation? Yeah, because there had been so many information in the history itself.
It's quite exhaustive, so she should summarize. Yeah.
So summarize, and
also, I think she already finished the history. She's coming for evaluation. I think it's, yeah. I think she's online now. Yes, Hia. Please
Dr.
carry
Hia.
on. Sir is telling, then you please go ahead.
Yes, my internet connection is a little bit creating problem. Actually, this patient, she is a 16-year-old. Am I audible, sir?
Yeah. You are.
Yes. This patient, she is a 16-year-old female, and she has been symptomatic since birth. And initially, immediately after her birth, her mother noticed that she did not produce tears while she cried. Okay. Then secondly, whenever she was given breast milk, she used to regurgitate all her feeds. And again, after 1 year of age, when complementary feeds were introduced, like solid and liquid feeds were introduced, she also used to regurgitate all the feeds. Then this patient, she used to eat very little, and whatever small amount she ate, it gave rise to retrosternal pain. And these symptoms continued. Then at around 7 to 8 years of age, they consulted a gastroenterologist. Gastroenterologist advised her some endoscopic intervention, but the family did not comply with the advice. And apart from this, they also this patient also gave history of generalized weakness, easy fatigability, and this diffuse darkening of skin. It started around 7 to 8 years of age. It started in the extremities, and then it gradually involved the entire body. And apart from this, she also had history of postural dizziness, and salt craving. Then, at around 9 years of age, because of all these symptoms, she was taken to a pediatrician, and that pediatrician diagnosed her as a case of primary adrenal insufficiency. And then she was started on tablet dexamethasone, which she took for around 2 to 3 years after diagnosis. And then after that, she resorted to tablet hydrocortisone and tablet prednisolone and then hydrocortisone. And before presenting to us, she was taking tablet hydrocortisone 10 milligram once daily. And around 6 months back, before coming to AIMS, she had a history of polyuria and polydipsia, and she was diagnosed with diabetes. Her random blood glucose was 245 milligram per deciliter, but HbA1c and other investigations were not done. And initially, she was started on insulin, but later on, she resorted to metformin. And while on metformin, she did not have any symptoms suggestive of diabetic ketoacidosis. This was the background history. Then around she presented to us with history suggestive of acute adrenal crisis. Like she had missed the dose of hydrocortisone around for 2 days, and she had episodes of fever with chills, which was accompanied by burning micturition. And when she presented to us, she had multiple episodes of vomiting, and she had also severe abdominal pain. She was lethargic, dehydrated, and she came in a state of shock. So that's the history.
Yeah, that's fine. So looks like a combination, a triad of three symptoms, mainly as you said, that alacrimia, and she had adrenal insufficiency, and also had problem with deglutition, which was not investigated, but adrenal insufficiency treatment was started rather in a not a very appropriate manner that we should discuss. And then you have the list of investigation. Okay, go ahead.
Yes, sir.
And tell those salient findings in investigations so that we can.
So yes, sir. Normocytic normochromic anemia, along with hyponatremia, hyperkalemia. Serum urea was slightly elevated, but creatinine is normal. And other investigations, calcium phosphate, ALP, liver function, kidney function tests are normal. Next slide, please. Next slide. HbA1c, as she was already diagnosed as a case of diabetes, her HbA1c was.
Yes, did you mention about the menstrual cycle of this?
Yes, sir. You're not audible.
16? Hello. Did you mention about the menstrual cycle?
Yes, I mentioned. She had normal menstrual cycles.
Right. Okay. Sorry. Go ahead.
It is regular, sir. It is regular.
Right.
Yes, sir.
Fine.
Sir, HbA1c, although she had a background, there was anemia, but still we did an HbA1c. It was 6.6%. She had evidence of urinary tract infection. Then we did a serum cortisol, which was done prior to injecting hydrocortisone, and that serum cortisol was around 1.6 microgram per deciliter. And the plasma ACTH was also elevated, which was 563 picogram per ml. And other thyroid function tests were normal. And plasma aldosterone was low, which was 2.9 nanogram per deciliter. And the direct renin concentration was also elevated, which was more than 500. And DHEAS was also low, which was 8.1 microgram per deciliter, and 17 OHP was also low, which was less than 1 nanogram per ml. Next slide. Next. Then computed tomography of the adrenals, it revealed atrophied adrenals on both sides. And because patient had background history of alacrimia and dysphagia, we investigated for the same. For alacrimia, she underwent Schirmer test in bilateral eyes, and this Schirmer test showed that tear production was less than 1 millimeter in both the eyes. And for dysphagia, we took a gastro consultation, and then patient underwent upper GI endoscopy. And upper GI endoscopy revealed a dilated esophagus, and there was narrowing of the GE junction. And the gastroenterologist, he had resistance in negotiating the endoscope through the gastrointestinal junction. So he suspected achalasia or with antral gastritis, and he did an antral biopsy. And this antral biopsy revealed chronic active gastritis. Helicobacter pylori test was negative, and there was no squamous metaplasia. Next. Sorry, Anubhav, can you please change the slide?
Yeah. Slide is here. No?
This is the high resolution manometry, which was done by the gastroenterologist. Now, yes, sir?
Go ahead.
This is the high resolution. Can you see the slides? High resolution manometry. So this high resolution manometry, it showed an elevated resting lower esophageal pressure, which was 39 millimeter mercury. The normal is less than 10 millimeter mercury, and it was 100% ineffective peristalsis. And the distal contractile integral, this DCI is distal contractile integral. It is 85 millimeter mercury per second, which is actually indicative of failed contractile waves. And the median integrated relaxation pressure is also high. So this is not much important for an endocrinologist, but this overall impression is that she is having a total loss of peristaltic activity in the esophagus. So by Chicago classification, this is classified as the classical achalasia cardia, that is achalasia cardia type 1. So now this patient is having alacrimia, achalasia with primary adrenal insufficiency. And so we did another test. Next slide, please. Anubhav, please change.
She's offline now. Anubhav?
Yes, she's gone offline.
Oh my God. Sir, SK Singh sir, what to do?
Yeah.
Nilanjan sir?
Yeah, I think we can start some discussion meantime, because she may be offline for quite some time. We don't know.
So it is about to be over.
Okay.
She has come back. Yeah. Okay.
Yes, ma'am. So,
sir, this investigations are we did this one. We did the autonomic function test, and this autonomic function test showed severe loss of sympathetic and parasympathetic activity, and there was also moderate loss of cardiac autonomic tone. Next. Diagnosis is primary adrenal insufficiency.
Yes.
Yeah, carry on.
The final diagnosis is primary adrenal insufficiency. The final diagnosis is primary adrenal insufficiency with glucocorticoid and involvement of both glucocorticoid and mineralocorticoid excess, and there is alacrimia, achalasia, induced diabetes. So the final diagnosis is AAA or Algrove syndrome with steroid-induced diabetes. Next slide.
Doctor, here you said Minlo and glucocorticoid, and why not there is an androgen deficiency also? Reticularis is also affected.
Yes, sir. The DHAS was also low, sir. And forgot to mention.
And right. Another thing, when you are getting adrenal atrophy, by imaging, there should also be logically affection of the
All three.
steroids too.
Yeah, all three zones. Yeah.
Just why it is not, it's adrenal insufficiency, why it's not a type 1 autoimmune diabetes in evolution? And if I want to argue why it's not type 1 diabetes in evolution.
Yes, sir. Type 1 diabetes. So because the patient did not have any symptoms suggestive of diabetic ketoacidosis, and even when she was off insulin, she did not develop any history suggestive of diabetic ketoacidosis. And apart from this,
another
she did
question
not
would
have...
be, Dr. Boro.
Yes, sir.
The another question would be that what are the situation where type 1 diabetic patients do not develop diabetic ketoacidosis, and one of the factor is underlying adrenal insufficiency. If they have very severe adrenal insufficiency, they may not develop diabetic ketoacidosis.
So counter-regulatory hormone deficiencies.
Yeah, they are off insulin.
Yes.
So that may not be a very, very right thing to say. But then we are, yes, we are worried why she had diabetes. This could be, as you said, related to steroid therapy also. But
yes,
we need to think about it, that why not this is type 1 also. Yeah.
Yes, sir. Yes, sir. And after that, after initial stabilization, the hydrocortisone was tapered off, and then the patient was switched to oral glucocorticoids. She was started on tablet prednisolone 5 milligram in the morning and 2.5 milligram in the evening. And she was also started on fludrocortisone 100 microgram once daily. She was asked to take oral salt ad libitum, and a patient and her family members were educated about the disease. Oh God.
Okay.
What happened?
Here, I think you
Anubhav, can you please share the screen?
You may switch off the video. That will decrease
Yes,
the
sir?
data transfer. You may try switch off the video.
Video. Only
okay.
audio.
Yes, sir. Yes.
Now it's clear.
Anubhav, please share the screen.
Screen is shared.
Yeah, Anubhav, please change the slide. What she meant. Just change the slide.
Okay, sir.
From 24 to 25th. Yeah.
And the other modalities of treatment was that she was given for achalasia. She underwent POEM, that is percutaneous oral endoscopic myotomy, and for this one alacrimia, she was given methyl cellulose teardrops. And for diabetes, she was started on human insulin mixtart 10 and 6 units, and her parents were also given genetic counseling. And then we also evaluated her sister, who also had similar manifestations. She was called for evaluation, and then we did a test of the sister as well. And this sister had also had a lower cortisol and a very high ACTH level, and she also had a low aldosterone and very high direct concentration. So the sister was also having manifestations which are suggestive of primary adrenal insufficiency, along with alacrimia. So this sister also had two components of AAA syndrome, also, although she did not have achalasia. Next slide, please. So the learning points are that this adrenal insufficiency is a relatively rare, but it is a potentially fatal disease in children. And the most common causes of adrenal insufficiency in children are congenital adrenal hyperplasia, and there might an autoimmune adrenalitis, which might occur either alone or in association with autoimmune polyglandular syndrome. And In India, tuberculosis remains a common etiology. However, we should also look for genetic diseases like adrenoleukodystrophies and ACTH resistance syndrome. Now, this ACTH resistance syndrome is a group of inherited diseases that include a familial glucocorticoid deficiency and another entity which is known as the triple A syndrome, which was seen in our patient and her sister. The triple A syndrome consists of achalasia, alacremia, adrenal insufficiency. Now, there is one more A which is added to this syndrome, and it was present in our patient as well. Dysfunction is also seen, but it was not present in our patient. And in children, both the glucocorticoid and the mineralocorticoid axis should be evaluated, and genetic counseling should also be offered. Next. And we should also, sorry, Anubhav, can you please share the screen? And once the diagnosis is made, the parents should be given, the parents and the family should be taught about the lifelong need for glucocorticoids and the mineralocorticoids. They should also be educated about the stress dosing, that stress dosing is required in any major intercurrent illness or any surgery or any major invasive procedure. They should also be taught that this stress dosing is not required in minor outpatient procedures, and the family should also be taught to carry a steroid alert card for the patient for all purposes and for all time. And when the child is able to understand, then this knowledge should be passed to the child as well. Next point. And this sorry, this is not visible. And for children, for children who have not completed their growth, hydrocortisone is the treatment of choice. And once the epiphyseal bone fusion has occurred and the child has completed his growth, then we can switch to longer-acting steroids such as prednisolone. However, dexamethasone is usually not preferred because of its more potential for causing side effects and more suppressive ACTH action. And whenever the patient is on steroids, we should always monitor for side effects like steroid-induced diabetes and Cushingoid features. And monitoring of the patient should be done regularly. We should assess both the glucocorticoid and the mineralocorticoid axis. Mineralocorticoid axis with by measuring the blood pressure and the direct renin concentration and the potassium, and the glucocorticoid axis by assessing a decline in the plasma ACTH level. Next slide. Thank you. This is Dr. Edison who first described Addison's disease.
Thank you, Dr. Hia, for.
So we have described the case of triple A syndrome, who had been symptomatic since the age of 2 years, since birth, and she had alacremia. Yes, sir.
Yeah, I think, yes, we have already heard about it. And this is the time for Dr. Rasha to comment on the case. We have already discussed the syndromic case, which is AAA. But then there are challenges in the management of this case, as we have seen. Challenges from both sides, from the physician side and also from the patient side. And that has led to the poor outcome of this case. And finally, it landed to a tertiary care center where it was nicely managed. So Dr. Rasha, your comments on the case, and then we'll make further discussion with Dr. Nilanjan and Dr. Jabbar.
Yes, okay. Good evening. Is my voice clear, Dr. Sanjay?
Yeah, it's very clear. Very clear. Yeah,
absolutely. Very clear. Good evening and welcome. Welcome to India, though virtually.
Thank you very much. It's my pleasure. Good evening, everybody. It's a real pleasure. I'd like to thank Dr. Sanjay for inviting me, the Endocrine Society, the organizing team. It's really a pleasure to be here with you and to visit India on a fast trip and go back. It's really nice to share experiences and knowledges especially among different populations. So I'm sure we're going to discuss this nicely. I'd like to thank Dr. Hia for presenting the case. And actually, what's in the case is not for the diagnosis. Yes, it's a clear case of AAA syndrome. But as mentioned, what happened as pitfalls from the beginning till the end, this is the issue. And there are a lot of learning points, I think, from this case. Starting by the etiology, as previously mentioned, in children, the most common cause is the autoimmune disease, the Addison, and the congenital types. And of course, congenital adrenal hyperplasia is on top of the list and should be always suspected. And now there are screening programs for that. So this is a very important point. In children, we think of congenital and autoimmune. The next point, learning point from this case is that the girl started since the neonatal period to cry without tears. So this is really an important clue. Parents are happy that the girl doesn't have tears usually. They don't think that this is a problem. And then the rest of the sequence of events happened later. This is because usually in AAA, the first sign is a lacrima, and then the achalasia and the adrenal insufficiency occur in childhood and adolescence, while the rest of the neurological manifestations and the autonomic manifestations occur later in adulthood. So it occurs in sequence. And what I mean here is that once we find something, we need to look for the rest. If there is a neonate who is crying without tears, this is an important thing, screen for adrenal insufficiency. Another thing is that the baby had feeding problems, which was interpreted at the beginning as regurg, simple regurg, that occurs in all babies. And the thing was that she was starting to have dysphagia problems, but was diagnosed later at the age of 7 years or something. Another learning point in this is that there is a various spectrum of presentation of AAA syndrome. For example, we can have various forms in the same family. The boy, I had a boy who had the typical features of AAA. His younger sister had a lacrima only. His other brother or cousin had dysphagia only. So it depends on the genetic mutation in the AAA gene and the encoding the Aladdin protein. So it's really tricky. We could find different manifestations in the same family. So this is regarding the cause. Now, going to the diagnosis, it was tricky from the beginning. I think adrenal insufficiency started a time ago before she was diagnosed at the age of 9 years. And let me tell you that in dark-skinned populations, like our populations, for example, in Egypt, in India, it's very tricky to diagnose adrenal insufficiency. It's easy in fair-colored people like Europe. Once they become dark, there is a problem. But sometimes what mothers come and say is that my child started to be easily tanned in the sun before having the full-blown picture of the darkness and the tongue and the gums and the knuckles. I think this needs time to appear. So progressive darkening could be tricky, and this is the challenging point of diagnosing adrenal insufficiency in our areas. Another point, the diabetes part. I totally agree with the comment that you said. Yes, she was on steroids, but it's not sure that it's steroid-induced diabetes. The general pediatrician should have investigated the diabetes properly to diagnose the type, because in children, it's type 1 until proved otherwise. So he should have continued the work up, doing the A1C, the C-peptide at that time, the antibodies, if possible. It could be preventing type 1 diabetes, though it turned out to appear by time. But yes, we should exclude other types of diabetes. Yes, going to the management, of course, I totally agree. Giving dexamethasone, yes, was a big mistake done by the general pediatrician, because, of course, the golden type of steroid in children is the hydrocortisone. And I think there is a problem with the availability. This could be an issue. For example, in Egypt, we struggle to find hydrocortisone. I'm not aware what's the situation in India. I'm very much interested in knowing, is there a difficulty in the availability of hydrocortisone or not? Because this could be an issue.
No, we don't have
Yeah,
that problem of availability, but it
Very
is a
good.
little costlier than prednisolone.
Dr. Hamza, we have a peculiar problem in this part, is eastern part of India, where
Yeah.
it is difficult to get hydrocortisone in rural areas, and
Yes.
very difficult to get dexamethasone in urban areas.
Right.
Oh,
Yeah.
You go to the rural areas, you get dexamethasone. We have to send the patient to rural area to procure dexamethasone for dexamethasone suppression test.
yeah. Okay. So
Because
it's
of the counter, out of the counter use in OTC use of dexamethasone is very much prevalent in semi-urban and rural India. I don't know what's the situation in Egypt. So
no, you
OTC
do
use.
situation. We have the dexamethasone all over Egypt. We have a very big problem with hydrocortisone. It's really difficult. Sometimes we order it from abroad. So this is a real problem in Egypt. It seems in India, it's a geographical distribution for the type. So that's good.
Yeah,
You
it
can
is true. Yeah, right,
You can
right.
fit it together. Yes. Another important practical point is that if hydrocortisone is not available and we are obliged to shift to another type of steroid, we need to use the calculator or the converter from one form to another. This is a very important practical point. For example, 1 milligram of dexamethasone is equivalent to 40 milligrams of hydrocortisone, equivalent to 10 milligrams of prednisolone. So it's very important to calculate this difference to give a proper dose in order to avoid overdosing and side effects of steroids. Another very easy clinical point which appeared in this case is that if the child is gaining progressive weight and not gaining proper height, this is a sign, clinical sign and easy tool that this is steroid excess as well. And another practical point, I think evident in that case, we do not need to normalize the ACTH. Yes, even if we measure the ACTH, if you want it very normal, we will give a very large dose of steroid and this will pose side effects. It could be high, accepted high ranges with the child growing well without side effects. And of course, the sample of ACTH should be withdrawn accurately, put on ice, frozen, because this affects the result. These are very important practical points. I think these are the main points in the case, and I'm happy for discussion of further points.
Thank you, Dr. Rasha.
Thank
Dr.
you.
Jabbar, your comments on the case? Any
Yeah,
additional
case,
point you
I
want
think
to add?
it's no, nothing. It's a beautifully worked up case. Okay, I agree with Dr. Nilanjan's comment. Okay, and I think Dr. Rasha also saying the same thing. It's a type of diabetes we need to sort it out. This could be a type 1 in evolution as a part of autoimmune syndrome, or this may be a part of the other one also drug induced. I think they usually, if the patient has got all four, like so 4A syndrome, that would be the appropriate terminology for this type of patients. 4A, all A's are there: achalasia, aclacemia, adrenal insufficiency, autonomic dysfunction. I think more appropriate term is, I think, 4A syndrome. I think this case is very good, and I don't want to make a lot of comments regarding this point. Over to Singh sir.
Yeah, another point I wanted to bring it out here is when you are treating these children with, as we have discussed, that treatment of choice would be hydrocortisone and not the prednisolone or dexamethasone. Dexamethasone will have more growth inhibitory effect. Prednisolone will have more metabolic effect and development of diabetes. Hydrocortisone would be safer among all these. But if you add fludrocortisone along with hydrocortisone, the dose of hydrocortisone will also be needed less, because fludrocortisone not only having a mineralocorticoid activity, but it does have some glucocorticoid activity also. So when you add fludrocortisone, you also give a little bit of glucocorticoid along with fludrocortisone. So combining these two, I think, would be of much help, as this will not have any adverse effect on the growth and also on the metabolic parameters. Like these children, ultimately, they are on steroid and under or overdosing, and they have a risk of lipid abnormality in future. They have risk of diabetes and bone effect because of excess of the steroid. So we need to be careful, and we have to teach all these things to the family, that they have increased risk of these things in future. Overdosing with fluorocortisone leading to hypertension and fluid retention, and that should be also identified. Otherwise, they will just put the child on antihypertensive drug. So many times pediatrician would put that child on antihypertensive. So we have to tell all these, because most of the pediatrician may not know it. As we have seen in this case also, dexamethasone was started by pediatrician. So I think these are to be taught very well to family, and put, this should be put on record, so that anybody who looks after the children will be aware of. Addison's or adrenal insufficiency is quite common. Somebody has asked, what about adrenoleukodystrophy? In this case, though it is 4A syndrome, as we have already said, but somebody asked adrenoleukodystrophy and when you suspect and when to investigate. That's a question by one of the viewer. So over to Dr. Nilanjan, would like to comment on the question. Adrenoleukodystrophy, when to suspect in a child with Addison's disease?
First, there would be features suggestive of adrenal insufficiency, but then there should be certain neurological pointers to that. That's the most important thing. If you have the neurological pointers, some neurological symptoms and signs that should point towards adrenoleukodystrophy, just as if you have this candidiasis, we would be thinking of polyglandular autoimmune syndrome. So that is a syndromic. When we are dealing with the syndromic things, I think we should try to have a high index of suspicion for the other syndromes. That's very, very important, because the point is that they will not present to the pediatrician or the primary care physician with a diagnosis writ on this face. So that we have to have an index of suspicion, some neurological problems, seizures, some spasticity or something would be white matter disease. That should actually alert. And of course, by neuroimaging and appropriate studies, we can follow up. The most important thing is actually suspecting the condition.
Yeah, and the male child always think of
male child,
especially male child, especially male child.
That's a good point.
I think nowadays there are thought process coming up. See, adrenoleukodystrophy, we thought is rare. Now see, when you discuss with our friends from neurology department, they're all seeing reasonably good number. So what I feel that, see, yes, sir?
The problem is not with the neurologist. The problem is when the diagnosis is not made. Because you see, in this case also, when the diagnosis was made, the algorithm was quite easy to diagnose. But when the patient presents just with dysphagia or just with no tears, means we do not have that index of suspicion. That's the similar thing with adrenoleukodystrophy. The early signs of adrenal insufficiency are failure to thrive, maybe like that only, a slight pigmentation here and there. And unlike in Egypt, our patients are more pigmented. So we don't take that as abnormal. And then the neurological things. So that's
good.
Yeah, that's a good point. Another question is that could it be ACTH resistance or the associated ACTH resistance? Then why there is a mineralocorticoid deficiency in this case? There's a question by one of the viewer, that if there is a possibility of ACTH resistance in this 3A or 4As, why there is a mineralocorticoid deficiency? So I think Dr. Boro can answer this.
Yes, sir. Sir, actually in ACTH resistance syndrome, ideally the mineralocorticoid excess is usually normal. But in AAA syndrome, which was earlier thought to be a part of this familial glucocorticoid deficiency, but now it is considered as a different entity. Here, when I reviewed the literature, I found that around 15% cases of AAA has been found to have concomitant mineralocorticoid deficiency in addition to glucocorticoid deficiency. So it is not always like that classical familial glucocorticoid deficiency where the mineralocorticoid excess is spared. In AAA, we may have involvement of the mineralocorticoid excess as well.
Yeah, and then when there is a long-standing long-standing resistance to ACTH, the adrenal blood supply is also not normal. So when all the zones are not working efficiently, the mineralocorticoid cells are also not getting that much of blood supply. So the long-standing secondary hypoadrenalism, one can have mineralocorticoid deficiency.
Actually,
That we have seen.
ACTH is trophic to the mineralocorticoid secreting cells also to the tune of 10 to 15%. It's not that absolutely it is under control of the renin angiotensin aldosterone axis.
Right. Yeah. Yeah. Dr. Rasha, want to add something?
I just want to add another, yes, please. For the mineralocorticoid part, regarding the treatment, I noticed in the case that she was given sodium chloride, she was given salt, I think for a long time. But what's the advice is that it should be given, I think, in the first year of infancy, when she's just feeding bottle fed or breastfed. But after that, they crave by themselves for salt. So we do not need to add salt to the treatment. Mineralocorticoid therapy will do the trick alone without adding salt after the age of 1 year. When they start to eat, they can take sufficient salt from diet, and God gives them the power to eat a very large amount of salt. They can eat a very large amount of salt. So I think there was no need to add salt for a long time after she was growing after the age of 1 year. This is another point that I wanted to add for the mineralocorticoid part. And as you said, yes, once we have glucocorticoid defect, we should check the mineralocorticoid defect and vice versa, even if the patient is not presenting with the typical symptoms, because sometimes it's a bit subtle or not evoluting from the beginning. So we need to keep an eye on both, not just the thing that the patient came with.
Yeah. Thank you, Dr. Rasa. There are a couple of questions related to the case. What about sustained release hydrocortisone preparation like Chronocort?
Yeah.
I think this is referring to, replacement with,
I also have a question. So what are the modalities of glucocorticoid replacement? I mean, hydrocortisone replacement you can think of, starting from twice daily or thrice daily, or what are the other newer modalities through the pump or whatever?
Would you like me to answer?
Yeah. What's your take?
Okay, there are some novel therapies, yes, in hydrocortisone evoluting. There is the continuous infusion pump, the hydrocortisone continuous infusion pump, and there are trials on that. And what's written in literature, it's very effective in congenital adrenal hyperplasia specifically, because they need to suppress the axis. They need much higher doses than the ones with simple adrenal insufficiency like the Addison. So it pumps hydrocortisone over 24 hours, and it's very close to the circadian rhythm. It achieves to some extent a good physiological level, but of course it is very expensive. This is an issue.
And challenging.
Yes, and there are the technical issues that happen with any pump, like the insulin pump or any other pump. So it needs well-educated parents. It needs a lot of money, which is an issue. Another thing is the sustained release tablets of hydrocortisone. These are long-acting type of hydrocortisone, which could be given twice a day instead of 3 times a day. And even more, there is a dual release tablet. And by dual release means that it gives the hydrocortisone twice, once immediately when the tablet is given, and then slow release later. And this is a bit physiological as well. This is an advancement, but of course, again, availability and money. The last thing is the Infacort. Infa comes from infants. The very low dose tablets of hydrocortisone, 0.5 milligram, 1 milligram, 2 milligram, 5 milligram, very small doses given to infants and neonates with adrenal insufficiency. And of course, it avoids the side effects, and you can calculate the dose easier instead of giving the 10 or the 20 milligrams. So these are the novel types of hydrocortisone, but we need money and availability as well.
Yeah, that's a good point, Dr. Rasha. And we should know that we will never use syrup preparation of hydrocortisone.
Yes.
Syrup preparation in infants should never be used. because you cannot ensure the
yeah.
concentration of the drug in the syrup preparation. The other point that if you get the fasting hypoglycemia in children on steroid replacement, it means that their evening dose is not adequate. So that should also be a point, and perhaps that would be a reason to change to these modified formulations of hydrocortisone, particularly the chrono or dual combination, dual preparations. Yeah, that's a good point. Yes. A few more questions. I think we have answered many. Somebody has asked about the natural course of dysphagia in AAA syndrome. This question is to Dr. Boro. Can you answer this? What is the natural course of dysphagia in AAA?
So I don't think there is resolution of the dysphagia, and the patient does have to undergo some endoscopic intervention. Like in our case, she underwent per oral endoscopic myotomy, and there are other measures as well, like botulinum injection and pneumatic dilatation, anterior cardiomyotomy. All these interventions are required to cure the dysphagia. Otherwise, there might be different types of dysphagia like type 1, type 2, type 3, but in our patient it was severe dysphagia, and without intervention it is unlikely to remit. So
yeah, this is a kind of a developmental problem, and I don't think that there will be resolution with time in dysphagia, and then autonomic dysfunction super
yes, sir.
added. So
And regarding alacremia, why alacremia occurs? It is also there is a hypothesis that because of autonomic dysfunction, there is decrease in the basal and reflex output of the lacrimal glands, which causes a decrease in the tear production, and that is why alacremia occurs in this AAA syndromes. Because of this autonomic dysfunction leading to decreased basal and reflex stimulation of the lacrimal glands. And
okay, someone has added there should be a 5A. Already we have talked about the 4A's. Somebody has added 5A, which is amyotrophy. I do not know if this is directly related to the syndrome 5A and amyotrophy. I'm not aware of that.
neurological dysfunction. There is 4A plus 1N, that is neurological dysfunction. This neurological dysfunction usually manifests in the form of hyperreflexia, generalized hyperreflexia, or there might be cognitive impairment as well. And sometimes even the Parkinsonian features might also occur, but I'm not aware whether amyotrophy also occurs in this
right.
disease.
So it's a more of a neurological than amyotrophy.
It's not amyotrophy. It's not amyotrophy.
Yeah. Right. Okay. So I think with that, most of the questions have already been answered. Someone has asked how to evaluate for adrenoleukodystrophy. Dr. Boro, just quick line
Yes,
on evaluation of adrenoleukodystrophy.
Yes, adrenoleukodystrophy is an X-linked disorder which occurs because of mutation in the ABCD1 gene. This ABCD1 gene encodes a protein that is responsible for the transport of very long-chain fatty acids into the peroxisomes. So in adrenoleukodystrophy, basically this beta oxidation of fatty acids is inhibited. So we will, if biochemical analysis, we get very high levels of very long-chain fatty acids. So this is one biochemical test which we can do. Another final confirmation is, however, done with genetic mutational analysis. For genetic mutational analysis, we will have to look at the X chromosome, particularly on hotspots for ABCD1 gene. So this is how we evaluate.
So biochemical evaluation would be easier. I think that's available also.
Yes, sir.
Biochemical evaluation, that is a long chain fatty acid, and the ratio of 20 to 24, or I don't remember, 24, 26, long chain fatty acid ratio by gas liquid chromatography.
Yes, and treatment with Lorenzo's oil.
Yeah, and treatment with Lorenzo oil in adrenoleukodystrophy.
Yeah.
Okay. Yes.
Sir, I would like to ask one question. Is there any specific treatment of autonomic dysfunction? Like our patient had severe loss of sympathetic and parasympathetic activity, along with loss of cardiac autonomic tone. So what can we do for that?
Dr. Rasha, would you like to answer this?
I think
medical treatment for?
we as endocrinologists, we don't add medical treatment. For the neurological and autonomic part, we usually consult the neurologist. We don't do anything except trying to keep the patient well by giving the hydrocortisone adequate doses and the fludrocortisone if needed. But actually, we do not treat the autonomic or the neurological part.
Okay, ma'am.
Yeah, very right. If you correct the glucocorticoid and mineralocorticoid, I think cardiovascular autonomic dysfunction improves a bit. But
yeah,
we cannot do anything for lacrimal and for other splanchnic GI involvement. So I think more of symptomatic treatment for these two we hardly have. Just like in diabetes, we don't have anything to offer these patients for autonomic dysfunction or other dysautonomia. We don't have anything in particular to offer. Dr. Nilanjan, your comment on?
Yeah, exactly so. Means whatever, once from the endocrinologist viewpoint, if you replete hydrocortisone and fludrocortisone, at least the vascular tone would improve to some extent. And rest is, even with the neurologist, it's a symptomatic thing, some sympathomimetics or something, as we do in frustrating, and even the cardiomyotony, the whatever you have done, of the achalasia, that's also actually a part of symptomatic treatment, because the essential problem is the dysautonomia, the parasympathetic nerve plexuses. That's why there's achalasia, but you are resecting the muscle. So I think essentially the symptom directed treatment, which will actually a palliative one, not a curative one. But I do appreciate that is best done under care of a neurologist. For us is to give glucocorticoid and mineralocorticoid supplement as needed, and that will improve the vascular condition, the autonomic vascular tone to a considerable extent.
Right. I think we have covered most of the aspects. I still see few hands raised. I do not know if there is a question. Oh, no, I don't see any question. If anybody wants to send a question, please do it, because we are close to the end of our webinar. Any question? Somebody has raised hand, but has not put the question in the question box. Please put question in question box or in the chat, wherever you feel like. Okay. I think we discussed this case at length. And yes, anybody?
Sir, stress dosing is required only in cases of surgery, trauma, and fever, and we don't need in any dental procedures or any procedure done under local anesthesia.
Yeah, for minor stress we don't need, but for yes. But again, remember, just going to this further, we are passing through COVID pandemic, and if you're a patient with adrenal insufficiency and gets COVID infection, there would be a risk of worsening of adrenal insufficiency. And for various regions, there are various explanations given for it. One, that it is a stress situation, so you need to increase the dose. Second, that they have demonstrated that SARS-1 virus had been found to be there in the adrenal gland. So maybe that SARS-2 is also there in the adrenal, and it might inhibit the hormone synthesis. Another is that the virus co-shares the ACTH amino acid, ACTH nucleotide sequence, and therefore there could be antibody against the COVID, might interact with the native ACTH, and that way it may further reduce ACTH level. So those who have normal adrenal function may have deterioration in the adrenal function. But in this case, that may not be applicable, as that's not a issue. Already patient is on replacement. But replacement dose may need to be increased because there is a stress situation developing with COVID-19 infection. So I think we have discussed few more questions coming up. We have little time. I think it was 8:15, so we have 5 minutes to go. Somebody has asked, dose of fluorocortisone to be increased during summer season when patients having more sweating or no need of such increment, what is the experience in hot country like Dr. Rasha's country? So
Very hot.
answer from that. Yeah.
We are above 40 now. Okay.
All right.
Yeah. If the child is well-oriented and he can sense that he is tired, he takes good amount of salt, he drinks good amount of water, we are checking his labs every 3 months regular. We do not need to do a special maneuver. But if we are dealing with a baby, you feel the baby is lethargic, is not doing well, we need to check the sodium at that time and offer extra salt if needed. But it differs according to the situation, according to the orientation, because some children are very well oriented. They can say, yes, I'm tired, I feel that I'm not well. They just take a lot of salt and water and they are fine. But this cannot be done if we are dealing with a baby or infant or a child who is not oriented. And of course, regular follow-up is very important. We check the adrenal functions, the sodium, potassium, every 3 months on regular basis. And if there is any stressful condition or sickness or illness or something like that.
Yeah, thank you, Dr. Rasha. There is another question, monitoring treatment with hydrocortisone. Somebody asked if ACTH level should be measured and how much ACTH level, when they should be measured. So, Dr. Boro, can you answer this? While patient is on hydrocortisone, monitoring of the dose by ACTH? Yeah.
So as such, there is no cutoff below which this ACTH should be brought down. But after initiating steroid, we expect a decline in the plasma ACTH level from the baseline, and I think it should be less than 500 picogram per ml.
Yeah, ACTH is not a good tool to know the adequacy of replacement or overdosing of hydrocortisone, because in order to suppress it, there will always be overdosing, as Dr. Rasha already said. So ACTH may not be a good parameter to assess the adequacy. Any Dr. Jabbar would like to add?
No, sir. No. See, ACTH is never a good tool for assessing the adrenal status in adrenal insufficiency, because that assay has got its own issue. Okay, and the cutoff, no real cutoff or real the target has been set. So I don't think ACTH is a good option, the monitoring tool.
Yeah. The last question: can we go for adding DHES to these patients who have DHEA level low? Now DHES is available for therapy. Dr. Rasha, your comment on any usefulness of?
I think no, it's not a classical thing to say that we can do. It's not like giving hydrocortisone or like giving fludrocortisone. It's not life-saving. And in a patient like the one we've seen, she doesn't have any pubertal problems. She doesn't have any other problems. So in such a case, I think we don't need to do this in such a case. It's not a vital thing like giving hydrocortisone or fludrocortisone, even though it is available.
Yeah, it is available on the counter
OTC.
also, I guess.
Yeah, that's OTC. That's a problem.
Yeah,
and in adult
on
medicine,
the counter.
There are recommendations also for using DHES for at least for 6 months you can use, but we are not using it. That's all, because we are not really convinced with the efficacy of DHES.
Yeah. It's not the classical thing, yes.
Correct.
Yeah, and there is no need in this girl also. There is no need of fine.
Pediatric
so
age, no.
Okay. So I think we should wrap up here, and thanks to all the chairpersons, Dr. Rasha, Dr. Jabbar, Dr. Nilanjan, and thanks to Dr. Boro for bringing out this beautiful case and engaging us in a evening discussion on the case. And first time to see Dr. Rasha in India, virtual image.
Thank you very much.
I guess you would be here sometime in one of the conference endocrine society.
I would love to come again.
All right. Okay.
Thank you, Doctor.
Thank you, sir. Thank you all.
Thank you, sir.
Thank you.
Thank you, everyone.
Thank you very much.
Just to give vote of thanks. Just to give vote of thanks, sir. I'll take just 1 minute. A very good evening, everyone. Firstly, it has been a very engaging and informative session on adrenal insufficiency. My special thanks to Dr. Sanjay Kalra for helping and guiding us for organizing the webinar series under the banner of EPIC. My gratitude to Professor S.K. Singh for chairing the session, sparing time from their busy schedule. for this webinar. I would like to extend my sincere thanks to Professor Nilanjan Sen Gupta as a chairperson for addressing and giving deep insight for the subject. I wholeheartedly thank Dr. P.K. Jabbar for being the national expert in this webinar. A very, very special thanks to Dr. Rasha Hamza for being the international expert and for a very informative panel discussion on the topic. Most importantly, I would like to thank Dr. Hiya Baru for such an educative and enlightening case presentation on the topic. And lastly, I would like to thank all the delegates for sparing time from their busy schedule and attending this webinar. We are looking forward for your participation in the entire series of our webinar sessions, that is EPIC series on adrenal medicine. A big thank you to all of you from Samarth Life Sciences family, makers of high zone, that is hydrocortisone and fluorocortisone.